Well, good morning everybody, and welcome to the launch of ANA's latest scientific committee review. It's certainly a topic that's generated a lot of interest judging by the number of people that have signed up for today's webinar. My name is Julia Lyon, and it's my pleasure to introduce our three panellists today. These three wear many hats, but today with their powers combined they make up the Agencies for Nutrition Action Scientific Committee. Our first panellist and lead presenter is Rob Quigley. Rob is the director of Quigley & Watts, a Wellington-based company that helps communities, organisations and families to thrive. Our second panellist is Dr. Rachel Brown. Rachel is a senior lecturer at the Department of Human Nutrition at the University of Otago. And finally, last but not least, Professor Grant Schofield, who is the director of the Centre for Physical Activity and Nutrition Research at AUT. The only housekeeping that you need to know is that at any point throughout the webinar you can ask the panellists a question. To do this, all you need to do is type your question into the question box on your control panel, and these will be answered at the end of the presentation. We'll also be recording the webinar and making it available on YouTube, so if you missed something and want to refer back to it, you'll have that option. But enough with the formalities. I'm now going to hand the presentation reins over to Rob so that he can introduce the latest report and take us through the key findings. So I am just unmuting you now. It's all yours, Rob.
Thanks, Julia. Good morning, everyone. Kia ora tātou. Welcome to the Agencies for Nutrition Action webinar on primary prevention and primary care. You have the slides in front of you and they should tick over as I talk. And we thought, because it's a webinar, we better put up some photos of who it is that you're looking at. That's me on the left there, in my shirt and tie, and I'm dressed exactly the same today. What you see is what you get. There's the lovely Rachel Brown from the University of Otago, and the equally lovely Grant Schofield from AUT University in Auckland. There's Nikki Chilcott and Julia Lyon, who are the brains behind the team and keeping us all on track for these for the webinar itself and also the scientific committee reports. This is the 6th scientific committee report the Agencies for Nutrition Action has done, and you'll be able to get this copy online right now of this particular one around primary prevention and primary care. There are 5 previous ones that are there. If you go to ana.org.nz and look at the scientific committee tag on the left hand side of the page, you will see there is one for television and obesity in children, one about the family environment and how that can impact on nutrition and physical activity outcomes, sugary drinks and obesity in children, the fabulousness of breakfast around a multiple number of outcomes, and the most recent one before this one we're presenting today is sedentary behaviour and chronic diseases. So they're all still there, and I can safely say they're all pretty current, and we haven't seen any studies that have come out to show that any of those recommendations or findings are off track. So please still keep using those. They're good, solid documents. Also, thanks to the peer reviewers of this particular report on primary prevention and primary care, Dr. Jackie San-Desai from the Health Services Research Centre at Victoria University and Rachel Blanche from Compass Primary Healthcare Network here in Wellington. This is possibly the longest titled report that we've ever produced, and so I've put it into dot points to try and help get across what it's all about. Nutrition and physical activity interventions, so they're the sorts of interventions we're looking at, just nutrition and physical activity. For primary prevention, so that's the type of intervention as well, in the primary care setting, so just primary care. Are they effective, and are they effective at doing what? At reducing biochemical and physical risk factors. So just those components. The outline for today, we're going to go through the background, the findings, the conclusions, and as Julia has already pointed out, please write down any questions as you go, submit them, and they will be emailed off by Julia to the other co-presenters who are listening in, and we'll be able to answer those at the end of the session. We'll probably have up to a quarter of an hour for questions at the end, so there's plenty of time to get through a number The first thing that we did with this study is that we thought we better define a few things. So what is primary prevention? Primary prevention is the attempt to prevent people from developing diagnosed diseases. That is, preventing people from developing disease in the first place. So imagine me, I'm a reasonably fit and healthy sort of person. I walk into my GP's office and he looks me up and down and does a few checks and he says, Rob, you're pretty good, but why don't you do this intervention to make sure that you stay well? That's what primary prevention is about. It's about trying to keep people well. So obviously with that sort of a definition, we focused on people who didn't yet have diagnosed diseases such as diabetes, heart disease or other diagnosed diseases. But many of the studies included people with at least one risk factor. So for example, they might have had high blood pressure, they might have had high lipids, or they might have had elevated blood glucose, but they weren't yet diagnosed with hypertension. So their blood pressure might have been elevated, but they might not have actually had hypertension as yet. So that was the primary prevention angle. We've got to be really careful on this one to recognise that we're not looking at secondary and tertiary prevention in this review. So secondary prevention is the treatment of a diagnosed disease undertaken in its early stages before it causes significant illness, and tertiary prevention is where you've got a diagnosed disease and the illness present and you're trying to prevent the disease getting any worse and restore function as much as possible. And you can imagine that primary care does an awful lot of this. Diagnoses people with diseases and tries to treat them and prevent the progression of that disease and return function to normal. And so we were not looking at this component around physical and activity nutrition interventions. We were looking at primary prevention. How do you keep reasonably well people well? What is primary care? And it is the first level of contact with the health system that a person would have, and the personal health services are typically delivered in a community type setting, and in New Zealand we would see this as a general practitioner, a practice nurse, mobile nursing service, community health services and pharmacies. What we did, the primary care definitions sometimes include wider things such as participating in communities and working with community groups, and we excluded those two aspects from the review. How do you do these types of literature review? Many of you have probably undertaken these types of reviews yourself, and you'll recognize that you do a pretty substantial search of multiple databases with help from librarians to identify appropriate search terms and databases to search for your topics. You typically cast a pretty wide net to start with and slowly whittle them down via exclusion criteria until you get to a point where you've included all of the studies that are relevant to the questions that you have to answer. And the exclusion criteria I'll go on to in a minute, and you'll see why we went down from those quite large numbers to a fairly small number by the end of it. We also used the World Cancer Research Fund's evidence judgment criteria. They're from 2007. If you're interested in how evidence is judged, and I use that word quite specifically, the judgment of evidence, because it's a whole topic in itself. The World Cancer Research Fund's got a couple of pages within their 400-page document about how they do that, and it's a really neat, tidy little way of judging evidence. And so that was, out of all the possible ways that you can judge evidence from around the world, there's at least 4 or 5 that I know reasonably well, this is a very tidy and neat way to do it. So we've been using that one for the last, for all of the scientific committee reviews, in fact. Some of the key inclusion criteria: English language, at least 6 months follow-up. As you'll see later, we broke the results into 6 to 12 months and greater than 12 months. And we were interested in studies reporting biochemical endpoints: blood glucose, blood lipids, anthropometry and blood pressure. And so you can imagine that as we're reading through these abstracts and the studies, we're going, well, firstly, is it primary prevention? So are these people already diagnosed with diabetes? for example, and sometimes it's hard to tell that from the abstract, and you only find it out when you pull the paper and read it fully. But also it's sometimes hard to tell what the endpoints that the studies were looking at, and we were interested only in studies that had at least some measure of a hard biochemical or physiological endpoint that we could look at. When we looked at the results, we saw that they could be neatly divided into three main types of interventions, and we chose to divide the results this way because we thought that that was a logical way for the sector to approach the information. You can cut these sorts of research findings many different ways, but we thought that cutting it by the type of intervention would be most helpful for the sector. So there are physical activity only interventions out there. There are nutrition only primary prevention interventions, and there are combined interventions which combine both physical activity and nutrition. And so please remember that we're only looking at primary prevention interventions in the primary care setting, not secondary or tertiary interventions, which is treatment of, for example, diabetes with physical activity or nutrition or combined interventions. Here's the first slide of results, looking at physical activity only. There were 9 studies, which is not too bad a number, pretty happy with that. 30 outcomes, a pretty decent number of outcomes. We've got across the top there the beneficial outcomes, the no effect on outcomes, and whether or not we identified any harmful outcomes. And down the left-hand side are the biochemical and physiological measures that we were looking for. So you can see that there were blood glucose outcomes, lipids, blood pressure, and anthropometry outcomes of interest in this one. And of the 30, 27 of those showed no effect from a physical activity primary prevention intervention, and 3 showed a beneficial effect. Those 3 beneficial outcomes were all from studies with less than 12 months follow-up, and the 27 outcomes were with no effect were all from studies that followed up the participants for greater than 12 months. So if you're looking at that result, what sort of recommendations would you make to your colleagues around a physical activity only intervention to change biochemical outcomes if you're working in primary prevention? What would you do if you were faced with something like that? Here's the nutrition only results. 4 studies in this situation. That's not many studies. When we come to the World Cancer Research Fund criteria for judgment of evidence, 4 studies doesn't give them a whole lot of faith, and we'll see that reflected in the conclusions. So only 10 outcomes looked at across only blood lipids, blood pressure, and anthropometry. Again, quite a mix of outcomes in this situation, both 5 beneficial outcomes and 5 no effect on outcomes. So a bit of a mishmash of results going on there, but nice to know no harmful outcomes. So first, do no harm, that's always a good thing. Like the physical activity one, when we looked across how long the follow-up occurred, there seemed to be a tendency that as you followed the participants up for longer, there was less likelihood of being effects. So all 5 of those no effects were in studies that were greater than 12 months, for example.